So now that we are in a quieter place to talk to you guys, hope you like it, the green atmosphere. Now I have my second question to John. Is there a difference how we experience depression regarding our age, being from different generations?
So in general, depression presents the same for everyone. It doesn't really matter. Symptoms are symptoms. Everyone can get them. It doesn't matter what age. But there are differences in clusters. For example, in terms of depression in the population, women tend to get more depressed than men, right? It's true. Women get depressed more than men. You have to watch the definition here, because if you were to also include, say, addiction, which is a way of masking depression, then men have more addiction problems than women. So it may just be a presentation problem and not a real affect in the population. Also, there are two main cluster groups that are affected more by depression than others. And that's the Gen Z population, so that's about age 15 to 25. They tend to have a higher rate of depression than the rest of the population. And again, men between the ages of 50 and 65 also have a higher rate of depression than their peer group, right? So than the women in that age group. In terms of population, that's kind of how it all breaks down. Everyone gets similar symptoms, which is how we know it is depression. It's how we define it.
And the next question would be, how do we feel when we experience depression? How can we identify it?
Clinically, we identify it through a cluster of symptoms. But basically how it feels for the individual, it feels terrible to go through. And if you've ever been depressed or are currently depressed, you already know this. You're going to feel feelings of grief, of guilt, sadness. You can also feel sense of hopelessness, kind of giving up on everything. Anger, irritability are also common features of depression, but that anger and irritability is more turned inwards towards yourself than it is expressed outwards towards other people. So you're kind of angry at the world in a sense, but it's more from your frame of reference. So that's generally how it feels. What I'm now going to talk about are some of the common symptoms that I look for as a clinician when people come in to talk to me. And as I go through this, I'd like you just to reflect on what I'm saying and see if you can identify yourself with any of these symptoms, because it'll give you some idea of how your mood is currently and whether or not you've got some of the symptoms of depression. The first one I'm going to talk about is this word called anhedonia. Anhedonia simply means the lack of emotional expression. So when people get very depressed, they go to what we call a flat affect. That is, they don't respond to anything. They don't respond to joy, so things that would make them happy, they don't respond to that. But equally, they don't respond to something that would normally irritate you and make you angry. They just stay flat in the world. And this is almost like that zombie effect you get with people. They live in the world without expression. The next one I'm going to talk about, we call it psychomotor retardation. And we think what depression is doing as a strategy is trying to get you to express as little energy as possible, so conserve energy. So it's going to prevent you from doing things like just doing anything. So the feeling you're going to get is you're going to want to stay in bed all day. You're going to feel like you don't want to do anything. Simple things that you used to do without thinking about, say getting off the couch and making yourself a sandwich. This would be a very simple task. When you're feeling depressed, it all of a sudden becomes a major issue. And it becomes such a major issue that the very thought of it just drains energy from you. And so what you end up doing is not getting off the couch. You just don't eat, basically. You decide because it's too much effort. I've heard people tell me that just chewing is difficult. So if you think of what the brain is trying to get you to do, it's trying to get you to shut down all your energy to conserve it all. And so this is what it comes down to. Stuff that you used to do before, that you used to enjoy doing, all of a sudden you don't get any good feeling out of it. So this is psychomotor retardation, because what it's trying to do is hold on, decrease the amount of energy you're spending, and hold on to everything. So you just sort of drop down into place. The next one we call vegetative symptoms. I think a lot of you can recognize that you get when you start feeling depressed. And this is a change in sleep patterns. Often it will be less sleep rather than more sleep, but it can go the other way as well. So some people will tell me that they stayed in bed, 12, 15 hours of a day, right? Because they couldn't bring themselves to getting out of bed. Other people try to get to sleep at night and they're so irritated, so agitated that they actually can't sleep and haven't slept barely any for days. So it's a change in sleep patterns. In the same realm, you also get a change in eating habits. So your appetite tends to decrease for the most part, but some people eat more when they're depressed. So it varies between the individual. If you're feeling depressed at this moment, you need to figure out which one of these you fit into. Another symptom of a vegetative symptom that we look for is a decrease in sex drive. So typically, if you think about it, sex itself requires the burning of a lot of energy. Depression is the conservation of energy. So your sex drive will just drop away, and people will report this quite readily, that this is a common symptom of depression. Your ability to concentrate, to focus on anything, tends to fall away because the whole act of focusing, again, requires that you engage your brain in an activity. And the point of depression is to pull back and conserve the energy you would put out in that. So people have difficulty concentrating, and that leads into work problems, obviously. Also, you'll find diffuse pains. People will come in and present to me, and they'll often have a pain in their back, for example. But it's not any specific injury that caused it. It's just this generalized pain they'll have. Or they'll get a pain in their stomach sometimes. They're called diffuse pain, right? So it's not a very specific incident that caused the strain. It's just this feeling of your body being sort of in suffering. And again, your body is trying to tell your brain that you're in pain and that it needs to keep and maintain the shutdown experience.
So can we tell actually when we feel on our different parts of the body that we might be really suffering from some mental problem, not necessarily a problem with our organs, let's say?
Well, this is in part why you have to see a professional, because they're going to start to ask questions like this. So you start off by going to your doctor to figure out whether you've actually got an injury, say to your back or, to your shoulder or wherever the pain's coming from. But often if there's no medical reason for the pain, then we move to the secondary reason for pain, and this comes from sort of the psychological reasons, and so that's where that'll come in.
I heard from people saying that they are cutting themselves or they are hurting themselves. Is that a part of maybe a depression, or what do you think?
If you think of what cutting is doing, right, and you talk to people who do cutting, what they're actually trying to do is feel something. And so they're cutting themselves in order to create pain, in order to be able to express pain. And remember I talked just earlier about anhedonia. This is this lack of emotional affect. And so they're inside, they're in pain, but they can't get it out. And so cutting then becomes a way to express the pain that they're actually trapped up inside them. Along with this, you'll see different other types of expression. One of the most common one is negative self-talk. That's talking about yourself and telling yourself, you're no good, nobody loves you, you're not smart enough, you're not pretty enough. These are this negative talk about yourself, right, often is correlated with depression. And if you think of the reason why, it's because it's maintaining a very negative worldview, which depression wants to keep you in anyways. So that's what it does. If I were to get you to write this down, you guys can try this. If you write down all the stuff you say to yourself, the negative self-talk, it's going to come down to about 4 words. I'm not good enough, I'm not smart enough, I'm not pretty enough. It'll always have very short sentences. And what you'll notice about those sentences is there's no analysis to it whatsoever. It's a basic statement that goes directly to an emotion. And the reason for that is this: those words that you're expressing were actually developed when you were a child. This is a childlike expression, which is why it's only about 3 or 4 words, and which is why it has no analysis to it. So if you try this on your own and you just write them out, you're going to see what I see all the time, which is that people go to these words because it directly links to pain. So they're using words they learnt in childhood, they're bringing it into adulthood, that gets them access to pain. And there is a way of getting out of that to stop doing that, right? You'd have to teach yourself not to go there because that's all it's doing. The other one that we frequently hear about are suicidal thought and suicidal attempts, and suicide, of course. Common with depression are suicidal thoughts. It's actually a lot more common than most people think. And in part, it's because the brain is trying to figure out how to get out of this situation. And it's being blocked at all sorts of different levels. And we'll talk in a different video about the neurobiology of this, because the brain's actually working against you to think your way out of the problem. People often start moving towards suicidal thought as a way of exiting depression, because depression's so miserable. So that's where that comes in. Where we get more concerned is when suicidal thought moves into behavior. When it crosses the line from thinking about it into doing something about it, that's when the level of risk increases, because now you're actually taking action to do something about it. It's important to realize you really need a professional pair of eyes on this, because it's not always the case that these problems present as high risk. For example, I had a patient once who has Crohn's disease, which is essentially inflammation of your gut, of bowels. It comes up, it creates a great deal of pain. And this woman used to have suicidal thoughts all the time. And she used to go into great detail in the planning of what she would do. And she wanted to use gas to kill herself. And she's even gone so far as to phone the companies that have that particular gas she was looking at. Normally, this would present itself as a big problem in my world. But because I understood that this was a coping strategy, that she had no real intent to harm herself, that she was using this method as a way of distracting herself from the pain, then I didn't get as alarmed of this particular scenario that she was describing. So it really takes a professional pair of eyes to look at the scenario, to look at the evidence all around it, to understand whether a person's at risk or not. So if you find yourself thinking about suicide or maybe acting out a bit, then I think you need to seek professional help to look at this problem more closely.
And I have a question there about the topic, John, because when, let's say, we have in our surrounding a person who is depressed and we know that, or we are aware that they might be suicidal, so what could we do as their surrounding, or parents or sisters?
Yeah, this is a very good question. So the best way to prevent suicide is through contact with other people. Suicidal people tend to withdraw from the world before they will attempt. And so the best thing you can do if you have a loved one like that is to actually talk to them about your concerns, to invite them and engage with them, to get closer to them, rather than, and don't be afraid to talk about suicide. No one commits suicide by talking about it. It's quite the opposite. If you're concerned about someone who's got that, then you need to sort of engage with them and sort of talk to them about it. That's the best thing you can do.
So basically we make them talk about their feelings, how they feel. We become supportive around them.
Yeah, you become supportive around them, but also encourage them to seek professional help, right? This is a concern. It's really got to do with connection with another person. That's really the bond that makes it more difficult for someone to commit suicide. And lastly, I'll just talk about another characteristic we see inside when I start to look at depression. And these are sort of rhythmic patterns. You may have heard of seasonal affective disorder. This is a form of depression that comes up with changes in the seasons. You see this more in the northern hemisphere because sunlight changes quite a bit the further north you go in the winter. And so people will get depressed because they simply don't get enough sunlight. And so that's why it's called seasonal affective disorder. And this will happen yearly. Every year it happens the same way. So these are depressive episodes, but they happen in a cycle. Because they happen in a cycle, you can predict it. And if you can predict it, you can then do something to prevent it. Another one that comes up is anniversaries. Anniversaries of a loved one's death, anniversaries of a breakup that you had, of a car accident, or anything like this. Anniversaries can often trigger a bout of depression. So these are other things that when I do an assessment, this is the type of stuff I'd be looking for. Lastly, we have past episodes. So if you think of how your brain works, it tries to predict into the future what you're going to need to do next. So if you've had past episodes of depression, there is already in memory a pathway for the brain to go down. It doesn't have to do any extra work. It just simply moves you over and says, this is what we did last time we were feeling this way. And it just slots you back in. This is in part why depression, once it starts, it can come up a number of times during your life, because it's not based on the one event. It's based on the brain's patterning along similar situations. So when I do an assessment, I'm also looking at that. The symptoms we look for are basically some emotional symptoms if you have them. So anger, irritability, sadness, grief, guilt, anything along that line. So we're looking for those things. Or we're looking for the exact opposite. We call that anhedonia. So it's a lack of emotional expression, on either positive or negative. Psychomotor retardation. So that's a withdrawing of the energy to do anything. Vegetative symptoms. Changes in sleep patterns, changes in eating, sex drive drops, diffuse pain, inability to concentrate, inability to focus. Self-injury of any type, including negative self-talk, but also any self-injury to the self, including suicide attempts. And finally, we look at rhythmic patterns that would have occurred over time. So see if I can look at any different patterns that the brain's trying to hold you in. If you've gone through all those and you see yourself with some of those symptoms, then you might start questioning whether it's a good idea to seek some help. Question whether you may be feeling depressed.
So if you think that you might need some answers to your questions, maybe start with commenting on below the video, and John have a look at your question, and then you can decide, okay, I need now help, professional help from someone in your surrounding or in your city or online even. Thank you very much for taking the time to watch this video. We see you in the next episodes. Take care of yourselves.